Pauline, I see you.
Yes, can you enable me to share screen?
Yes, I'll make you a co-host.
And same with me, Pam.
Okay?
Thank you.
And I will be doing the screen share for Dr. Jallo.
Yes, fine.
All right.
Okay.
Well, I am going to let in everyone from the waiting room if you're all ready to go.
Yeah, we're ready.
All right. Here we go. And I'm going to ask our speakers to unmute yourselves. Everyone else is muted.
Good afternoon.
Welcome, welcome, welcome. Good morning, good afternoon, good evening. Welcome to the second in the spring webinar series, which the International Association for Spiritual Care is laying on. It's a joy and a delight to see and experience everyone present with us. My name is Emmanuel Latte, and I have the honor of serving on the executive of the International Association for Spiritual Care. I also spend a fair bit of time teaching pastoral theology and spiritual care through Emory University in Atlanta, Georgia. And it's a delight to welcome each one of us. On this occasion, we are considering the meaning and the practice of spiritual care from the perspective of public health practitioners and teachers. Next week, the focus will be on the discipline of psychology. The week after that, the discipline that will provide the focus is nursing. And then the 2nd February webinar will have pastoral and spiritual care practitioners reflecting on spiritual care. So it is my great joy to welcome 3 speakers for this occasion. John Blevins, Pauline Njiru, and Mohammed Jallo. And I will at this point say a few words of introduction for them. And then they will proceed without further introduction and speak in the order in which they are introduced. And then we will, after that, have a period of breakout where we will have the opportunity to reflect with a few people on what we have heard and formulate any questions that we may have, and then return into a plenary session and take questions and responses at that point. And that will hopefully usher us to the end of this seminar. So let me say a few words first about our first speaker. Dr. John Blevins is an associate research professor at the Rawlings School of Public Health at Emory University. Trained in religious and theological studies with an emphasis in pastoral theology, John is the director of the Interfaith Health Program at Emory, an initiative that aims to understand the varied influences of religion on individual and cultural beliefs, perceptions, and practices related to health. John is also affiliate faculty in the Graduate Division of Religion in the Laney Graduate School at Emory. He actively works on initiatives at the intersection of religion and global health in over a dozen countries around the world. John has authored numerous academic articles on religion and public health and is the author of To Transfer the Empire of the World, Christianity's Role on United States Global Health and Development Policy. The Reverend Pauline Wanjiru Njiru is a priest in the Anglican Church of Kenya. She's joining us from Nairobi, working for the World Council of Churches Ecumenical HIV and AIDS Initiatives and Advocacy as the Eastern Africa Regional Coordinator. Pauline is a PhD candidate at the University of St. Paul's in Kenya, in Limuru, Kenya, specializing in mission studies. Her areas of expertise include gender, transformative masculinities and femininities, HIV, working with people on the margins, especially grandmothers parenting grandchildren orphaned by AIDS, and people living with HIV, spearheading intergenerational safe space conversations, and mentoring young people. Mohammed Bela Jallo is the director of Focus 1000 in Sierra Leone, and he formerly worked with UNICEF. He coordinates interreligious initiatives to improve child health. The initiatives work with Christian clergy, Muslim imams, and traditional healers to address childhood illness and death in every district in Sierra Leone. Building on this network, Mohammed Jallo has also coordinated emergency response programs with faith leaders and faith communities in response to Ebola and latterly in response to COVID-19. So it is a great delight to welcome our three presenters on public health, beginning with Dr. John Blevins.
Thank you, Emmanuel. Give me just a moment as I share my screen. Can you see the PowerPoint? Great.
Yes.
All
Yes.
right. Thank you. And it's a pleasure to be with you all and to see some old colleagues from my background and work in the field of pastoral theology and virtually online to see them and to be with my colleagues in public health responses with Pauline and with Mohammed, who are colleagues in ongoing work today. So thank you for having me. In thinking about this question of the relationship between spirituality and public health, I wanted to name some challenges in the framework of opportunities or new insights that arise by understanding the intersection of religion and public health, and to do that from a religious and spiritual perspective and from a public health perspective. And having laid out those challenges and possible opportunities that can arise in this context and from this intersection, to then discuss some of the implications of those. In regard to the religious and spiritual perspective, one of the challenges and one of the insights and real growing edges that I experienced when I moved from working both in clinical settings and in teaching settings in the field of pastoral theology and pastoral counseling over to the School of Public Health over a decade ago, is that I had been trained in clinical models within both community-based and clinical settings, and in psychological theory to frame the focus of the pastoral question and the pastoral response in a relation to the individual. Now, the field in the past generation had already begun to address what John Patton called communal contextual dimensions of pastoral theology and pastoral care, and in the intervening decade has really developed and heightened that focus. But historically, the field of pastoral theology and the dimensions of thinking about spirituality as a dimension of human life and spiritual practices, when I was trained in my own master's and doctoral studies, focused on the individual, both in clinical practice and in theoretical foundations. And that doesn't align very well with public health. Public health focuses not on the individual, but on the question of health at the social and population level, really focusing on what the field calls the social determinants of health. This focus presents both a challenge and an opportunity for our ongoing understanding of thinking of spirituality beyond individualistic dimensions of human existence and beyond individualistic levels, and to really understand spirituality in a more holistic and interconnected way. The field of public health thinks about the connection between the micro or the individual and the macro or the societal or even cosmological by thinking of social structural factors and forces that impact health outcomes, what we call social determinants of health. But the question that always was vexing for me when I first moved from this field is, what does spiritual practice look like in that context? And I remember one of the first kinds of reflections out of religious studies that helped me to get a grasp on the connection between the two was some work that colleagues in South Africa did in which they described a research initiative that was designed to identify local religious health assets that could be in partnership with public health initiatives, and to understand how local non-governmental organizations, local faith communities, local faith-based organizations in both Zambia and Lesotho could be brought into closer partnership and collaboration with public health. But what they realized as they carried out the work in Lesotho is that the question only made sense from a Western lens. For the Sesotho people, and using the Sesotho language, the idea of asking what role religion played on public health was nonsensical, because the Sesotho word bopelo was the same word for both religion and for health. It was a framework for a cosmology that encompassed both health and spiritual practices, that encompassed both the individual and the community, that encompassed both this world and a broader cosmology of the divine, as well as ancestors who had gone before us. And it was the first realization I had of the kind of limitations of a Western model that created these kinds of categorical silos that I had been trained in. And so I think for spiritual practitioners and those in the field of spiritual health, public health is an interesting field of practice and study for helping to interrogate the social cultural dimensions of our work and how spirituality intersects with those. From the public health perspective, the challenges as well as the opportunities for thinking about public health and spirituality come from the ways in which public health at times, and quite often actually, fails to really respect and appreciate fully the spiritual dimensions of human existence. And I want to give an example from a large public health initiative that I'm working on now, and I actually work on this in collaboration with Mohammed Jallow, one of my panelists. He is part of a team that's working on this same project in Sierra Leone. The project is called CHAMPS, which stands for Child Health and Mortality Prevention Surveillance. It's a large-scale, multi-country mortality surveillance project to understand the causes of death in children under the age of 5 years old. And the epidemiologists and the clinicians and the laboratory scientists who are part of the initiative see this project as a potential game changer because it provides us with more scientific and pathology data for identifying with much greater specificity and granularity the causes of death in children under the age of 5. It does that by carrying out what's called a minimally invasive tissue sample, which is a way to gather small samples of tissue from bodily organs and small samples of bodily fluids from the body of a child after they've died. And they see it as a game changer because it allows for a practice that circumvents some of the deep standing misgivings or tensions with carrying out a complete diagnostic autopsy in which an incision is carried out on the body. But in reality, on the ground, and we're now active in 7 countries around the world, the minimally invasive tissue sampling procedure is itself still a practice that's in tension with deeply held spiritual beliefs. That tension varies from country to country, but it's present. It's definitely present in the countries in which we work. And CHAMPS has to, if it's going to succeed at all, has to demonstrate the importance of that scientific data and that body of knowledge in tension with the importance of the spiritual practices that occur at the time of death of a child and what those spiritual practices signify and what they accomplish, not only in the symbolic realm, but in actuality from the point of view of people working and living in the communities where CHAMPS is working. My public health colleagues are really committed to trying to be respectful, but they often demonstrate respect in this way. Help us to understand why these practices are so important so that we can help you modify them so that we can get to the real work of carrying out the procedure that is essential for us to gather the data that matters to us. And that creates a real point of tension and a kind of rhetoric of respect that in fact can often be deeply disrespectful to local communities and local cultural contexts. The challenge that CHAMPS represents is how do we overcome that? And what can public health learn for not just giving lip service to the importance of a spiritual worldview, but actively building partnerships in local communities that are grounded in public health science and research while also respecting those spiritual frameworks. And so here are some key issues I think we need to consider. Religious and spiritual practices in community, when they specifically intersect with public health, are not always, but are often a negotiation in which the question comes up as to whose priorities will take precedent. And we can't simply give lip service that your priorities matter as long as they don't get in the way of ours. But because of technical capacities, funding inequities, and funding priorities, those questions are not sufficiently interrogated by my colleagues in public health, I would argue. In such a context, religious leaders can help to play an essential role as intermediaries by providing a framework to identify common shared commitments and perspectives that will allow us to forge a common ground and a way forward, and to adapt spiritual practices so that public health priorities and outcomes can also be achieved without running roughshod over religious beliefs. Those kinds of deliberations to find that common ground are often deliberations and debates between insider and outsider groups. And there is an important qualitative difference between members of a local community debating whether a procedure such as the minimally invasive tissue sampling of CHAMPS, this MITS procedure, is acceptable, versus a public health authority coming in and advocating that it is acceptable and how can we best ensure that you'll agree to it and accept it. Those kinds of debates are important to attend to in regard to cultural dynamics as well as to issues of power that come into a play. And so how do we engage in that negotiation? In my experience, there are some elements that are absolutely essential to pay attention to in regard to the negotiation of relationships and perspectives as they play out over time. The first is the issue of trust, which is grounded in regard to the outsider public health leader keeping their word in regard to what they're promising and to the promised benefits of the public health initiative that's coming in. If there has to be a change in regard to why those promised benefits can't be made available in terms of the project didn't work to achieve the outcomes that we had hoped for, that has to be communicated openly and transparently. The nature of the relationship, religious leaders and faith communities are part of the fabric of a local community. They're there long before a public health program or intervention comes in. They'll be there long after a public health program or intervention that's grounded in a funding stream leaves. And we can't simply come in and out of communities and run roughshod over the nature of those relationships. But if we don't pay attention to those dynamics, it's quite possible that an initial relationship that can be promising will actually begin to deteriorate and will become worse rather than becoming better. And we need better ways to spot that, and religious partners can be key for helping us to see that. And then finally, from the point of view of attending to issues of power, grassroots and local efforts in public health can often be context for understanding and to see the blind spots of our larger scale initiatives that are playing out at a national level, and to engage with partners, not just within the mainstream, but also at the grassroots. Some of Pauline's work in the area of HIV and AIDS helps us to see that understanding how people who are marginalized because of stigma in relation to HIV still engage agency and employ agency and power in their own community and cultural context can be really revealing for how some of our initiatives engaging faith leaders may actually reinforce that stigmatization for marginalized communities. And listening to how people who are on the margins frame their own kind of spiritual practices is really essential for understanding how we develop approaches in public health that are more holistic and speak to the variety of spiritual practices in local contexts. Those are my initial thoughts, and I look forward to the discussion that ensues.
Thank you so very much, John. Thank you. Pauline will present now. Please unmute.
Thank you very much. I am looking at spiritual pastoral care during pandemics, and I'm looking specifically at how the response during HIV and AIDS has been replicated again during COVID-19. My presentation will draw from my PhD work, which is the impact of stigma on grandmothers parenting grandchildren orphaned by AIDS. And based on the experiences of the grandmothers against poverty and AIDS. These are grandmothers who are parenting grandchildren orphaned by AIDS, and their HIV and AIDS related reality, the fact that they had their own children acquire HIV, and in a time when antiretroviral drugs were not very readily available, and most of these children then died, leaving behind a trail of grandchildren in the care of the grandmothers. This reality was so devastating, such that these grandmothers felt overwhelmed and went looking for their pastors for the much needed spiritual and pastoral care. Now, what happened when they looked for the pastors? We see that the research reveals that the pastors were not available. In other words, they were not ready to give the much needed pastoral and spiritual care. So the pastors responded negatively to the grandmother's cry. They labeled them, the homes, they labeled their homes, the homes of ants. They stigmatized them alongside the community. They also joined the community in isolating them, discriminating, abandoning, and shaming them. So we look at why this much needed spiritual care was not available, or why is it that the pastors did not, why is it that the pastors did not offer the spiritual and pastoral care needed? We realize that the early responses to the HIV pandemic propagated and sustained fear and other factors that hindered pastoral accompaniment. Some of these being associating HIV and AIDS infection to sexual promiscuity. You'll know that in Africa, sex is a taboo. So if the disease is associated to sex, then it hinders any positive interventions. Then there was also the lack of accurate knowledge and information relating to HIV. There was a lot of misconceptions and myths. There was lack of adequate theological training on the part of the pastors, and there was also confusion between faith and public messages, such that the pastors confused the messages of health and the messages of faith, offering both or interacting both and causing confusion in the responses that were given. So just a minute. The observations that we have made in COVID-19 is that similar approaches have been applied and the same factors are in play. For example, early responses of COVID-19 propagated and sustained fear and other factors that have continued to hinder spiritual and pastoral accompaniment. One of them is associating COVID-19 infection to sin and branding it a punishment for sexual immorality. We saw in the very early times in our context, vocal pastors saying that God was punishing the West for practicing gay marriage, and they even prophesied that Africa will be spared. And this therefore was influenced by similar determinants that influence the responses of HIV. Again, inadequate knowledge and information, misconceptions and myths, lack of inadequate theological training. For example, you find a pastor saying, a pastor offering communion to the congregation members using one spoon, and when challenged, he says, I have been distributing communion since the time HIV was bad. Up until now, I've never contacted HIV and AIDS, somehow implying that using the same spoon will not be a risk in the age of COVID-19, which shows that the person already has inadequate information, and also their theological understanding is mad. For example, also arguing that COVID-19 cannot be transmitted through the elements because the elements become the actual body and blood of Christ. And the question then becomes, what about the vehicle or the vessels that hold the bodies of Christ? Are they also transformed? Are they capable of passing the virus? So there is this also the confusion between faith and public health messages and interventions. We see that some pastors will say that if we are in the church praying and praising God, COVID-19 cannot find us there. If you are singing or praying together, COVID-19 cannot find you there. And it shows that there is confusion between faith and public health. The feeling that faith can prevent you from contracting a disease which is contagious. And therefore, there was also the risk factor which influenced the responses. For example, the fear of contagion. One of the observations that we have made during this time is to see that during when COVID-19 came and the government started shutting down activities, the churches were shut down. And the churches were shut down, and when the churches were shut down, the pastors began to say that they have not been considered as essential workers. So when the pastors were called upon in the era of HIV and AIDS, especially by the grandmothers, to offer the much needed spiritual and pastoral care, they ran away. They also sent away those who called them. We had instances of grandmothers saying, "My daughter is dying. Can you please come and pray with her?" And the pastor would not go anywhere near. Or even saying, "My son has died. Can you please come and say prayers at the grave?" And the pastors would not go. But during this time of COVID-19, the pastors came out to complain that spiritual and pastoral care was not being considered as an essential service. And therefore, you see, there is the need, therefore, to investigate why during this COVID-19, pastors complained, yet during HIV and other pandemic, they did not respond when called upon to offer the spiritual care. Before even we respond to that, we need to interrogate also this failure and denial of pastoral care. What does it do to the congregation who very much need it, or to the people who very much need it? In my research, the grandmothers refused to take this lying down. They realized that there was a gap in the pastoral ministry. They realized that the pastors had missed it. They realized that the pastors had missed the mark. They had failed to understand about the pandemic HIV. And therefore they stood up and challenged the pastors to come forward and understand the pandemic so as to respond positively or appropriately. During the COVID-19, we see that we need to interrogate what is driving the pastoral care or the urge of pastoral care from the pastors. Are the pastors being denied to care for the people living with the pandemic or affected by the pandemic? Or what do they interpret being asked to close churches and being able to offer pastoral care? And we saw that during this time, there was so much innovation, social media, internet, live streaming of worship, but still the pastors kept complaining, we are not being considered as essential service. So there is need to unpack that pastoral care, pastoral spiritual care, accompaniment. What is it? How does it need to be packaged? Who needs to offer it? Who needs to receive it? Who prepares the person who offers it in terms of training and other accompaniments? So there's need to really investigate why the church finds itself inadequate to respond to these pandemics. There's need, therefore, to see where the interlinkage between public health and pastoral and spiritual care need to happen, especially in theological training. So we see that the implications for theological institutions, therefore, is the need to interrogate their curricula. Before, during, and after pandemics, theological institutions should prepare the pastors to be in a position to offer pastoral care. And therefore, public health should also be incorporated into the theological curricula, because we see the misconceptions that were there during HIV are still being experienced during COVID-19. The mix-up during HIV, pastors preach that if you are born again, you cannot contract the virus. In COVID-19, we have heard that if you are in the church praising God, you cannot contract COVID-19, which shows that there is a disconnect. There is a disconnect that the pastors may not quite be understanding the issues of public health and how that relates to faith and to spirituality. And therefore, there is need also for the established theological institutions to find ways of reaching majority pastors who are not theologically trained, who are out there and they have the call to serve and to accompany people spiritually and pastorally, but they do not have the tools or the skills. Yes, thank you very much.
Thank you. Thank you so very much. We will now hear from Mohammed Jallo. Mohammed Jallo from Sierra Leone.
Yeah, well, thank you so much. It's a pleasure to be here. And, I hope and pray that, we'd all be able to get, something out of the presentation. Let me start by just saying that for us in Sierra Leone, for a long time now, we've been able to look at the issue of spiritual care and public health and see how we can compromise and combine the two. Next slide, please. So in Sierra Leone, quickly, we have, in terms of Muslim and Christian population, we have 78% Muslim, Christian, and traditional 1.3. But the good thing about Sierra Leone, in terms of the context, is that it's a secular state. But most times, even when we want to start meetings, we invite both the Muslims and the prayer and the Christians, to do their prayers. And then there is a lot of religious tolerance in Sierra Leone. That is already a plus. Even in the courts, when you get to the courts, they give you the Bible and the Quran. Both of them, the two books are in the courts. And if you're a Muslim, you use the Bible. If you're a Christian, you use the Quran. So I mean the other way around. If you're a Muslim, you use the Quran. And if you're a Christian, you use the Bible to show the acceptance, even at the highest level. Even when we have, events, you would find out that Muslims and Christians, would come together. We celebrate Christmas, and the Eid. I mean, it's really, a lot of, tolerance going on. So I think that one already helps us. Vast majority of the population have strong belief in spiritual care, and so you find out that even during the war, fortunately, it never degraded to a religious war. People work together, in terms of the COVID and in terms of, the Ebola. Next slide, please. Next, please. Yeah, so when we did our study on COVID, we wanted to find out, people's perception in terms of risk. And a good number of people said they did not see themselves, at any risk. And those people who said they didn't perceive any risk for themselves, you would find out 62% of them said they are not at any risk because they are protected by God. That shows how deep-seated, our religious, beliefs are. Next slide, please. Yeah, in Sierra Leone, we believe that we have, and these are people who are really trusted. They use local herbs, to treat certain diseases, and people know, they would make their specification. If they have diarrhea or gonorrhea, they know where to go. If they have, mental problems, they believe they can go to the spiritual healers or the traditional healers. They are often consulted when there are problems, with marriages, problems, with what they would refer to as sin and all those type of stuff. Traditional healers are usually the first port of call for many Sierra Leoneans, when they are sick or their children are sick, even when they want to go to the hospital. It is not uncommon for them to go first to the traditional healers to ask, the imam or the pastor to ask for some blessing before they go to the hospitals. So I see that you would notice that already we have the complementarity of both Next, please. Yeah, so in Sierra Leone, we've had a lot of good experiences working with religious and traditional healers. When I joined UNICEF in 1986, we had the Universal Child Immunization Program, and the objective by then, it's a global program, was for countries to achieve at least 75% immunization coverage by 1990. When I joined in 1986, Sierra Leone was at the level of 6%, and with the involvement of religious and traditional healers, we were able to move the coverage from 6% in 1986 to 75% in 1990, a big achievement. During the and the rebel forces. So they came in and intervened. And since then, we've been able to use traditional channels, the imams and the pastors, the mosques and the churches, to promote facts for life messages in terms of breastfeeding, oral rehydration therapy, family planning, food supplementation. Because when you give these messages, by the traditional healers or the religious leaders, they are more easily accepted. We've worked with religious leaders in the polio eradication campaign. That's one, we did in Sierra Leone, but even when I was working for UNICEF globally, it was one of our major strategies because, there is a lot of resistance. At one point, the polio eradication campaign was getting so close to final achievement. When I was in Nigeria at that time, Nigeria said they were going to stop the campaign. So we had to go and work with those traditional leaders and the religious leaders to restart the program all over again. It shows that it has a global reach and global impact. During the Ebola campaign, the Ebola epidemic in Sierra Leone, some people thought that it was the traditional healers who were responsible for the transmission of the infection. A lot of traditional healers died. Religious leaders also died. They were infected in the process of healing sick people. The thing was that, from the medical side, the key message was that Ebola had no cure. But it
As soon as we get Dr. Jallo back, I'll bring the screen share back up, but I wanted to see if I could see him on the screen. I think he's lost his connection.
Right.
What would you like to do, Emmanuel?
Perhaps we could continue through the slides?
Right.
Oh, he's back on. He's back on.
Right.
Okay, I will share the screen. Thank you very much.
Thank you.
All right, we'll resume where we left off here.
Hello.
You're back. Okay.
Okay, I'm very sorry about that. Yeah,
Wow.
it's just a matter of the connectivity of the, not stable. But then I was just saying how we've worked with religious leaders, get them to change those cultural practices. Because, most times people would deny, the issue of washing dead bodies, the issue of traditional burials, which were the key mode of transmission of the Ebola infection. It was very difficult to get people to change those practices. But when we involved the religious leaders and the traditional healers, they were able to make a difference. They were able to use verses from the Quran and the Bible to support the public health messages, which we did for Ebola, we did for COVID also now, we did for immunization. So one of the experience we've had is that most times, if you challenge the religious leaders, they can go into the Bible and the Quran, identify relevant verses to support the public health messages on hand washing, not even burying and bodies, when the example of the Prophet of Islam who buried his own disciples without washing them. So that was very powerful when you get those relevant quotes from the Bible and the Quran to support the public health messages. Let's get the next one, please. Yeah, so we have this network of the Kumbara network, where we bring in traditional healers working with religious leaders, market women, civil society organizations, and the media. They work together as one so that they have the same messages. Instead of contradicting themselves, they are all saying the same thing. And we find out that is very powerful, because when you leave them working alone on their own, most times you find out that they give contradicting messages. So I think, bringing them together, the religious leaders, traditional healers, helped us, in making sure that they were all on message. Next slide, please. Yeah, so you can see, in the mosque, and in the churches, we have small groups. Then during Ebola, we had the religious leaders, saying, they support the Ebola campaign. When we had, stigmatization of the survivors, the religious leaders would go, and once those people have been declared safe, the religious leaders will hug them to show that they are now, safe, to avoid the issue of discrimination and, stigma. That helps a lot. We would also be using the media. What we do, we bring religious leaders or traditional healers on radio and television, because we find out that radio and television go far. But then when you now combine that with religious and traditional healers, you have, greater impact. Yes, please. Next one. Next slide, please. Yeah, so like I said, we challenge the religious leaders to look at the Bible and the Quran, identify messages to support the public health messages. So we don't contradict the public health messages. We just make sure that, the religious messages are supporting the public health messages. We develop the messages, we field test the messages, and then we finalize. We develop IEC materials with the public health messages. we develop sermons. You know, we get the imams and the pastors to develop sermons, which they use in the mosque and the church. They engage communities through visits, and they facilitate research. So this Kumbra network, you would see the religious messages, you know, that have been developed side by side, the Islamic messages and the Christian messages. This has even helped to harmonize, you know, promotes complementarity between the Muslims and the Christians. Next slide, please. Next, please.
It's there.
So now, yes, we have the program in all the districts, all the 14 districts in Sierra Leone. We have our national executive, we have our district executive, chiefdom, and section executives. We have now been able to engage about 6,000 religious leaders, imams, and pastors, about 200 traditional chiefs, about 4,000 market women, about 120 youth groups, 70 media practitioners, and 200 CSOs. So this is a very powerful, you know, network, you know, and about 10,000 traditional healers. They are all over the country, in each district, in each chiefdom, and in each of the sections, right down to the community level. We have done a mapping of them. We have their names, their telephone numbers, the churches and mosques in which they, you know, operate. Next slide, please. Yeah, so we have also, that's what I'm just saying, digitalize the entire, you know, national reach, so that we now have a sort of database of the religious leaders, the traditional healers, market women, according to district, according to chiefdom, according to mosques and churches and communities. And we work with them regularly. We have a WhatsApp group called the Kumbra Network, you know, WhatsApp, where we you know, promote messages using the social media. Like I say, we also put them on radio and television. And we you know, we are in touch with them, you know, with by email, those who can read, and then we use, you know, text it. Next slide, please. Yeah, so this finally, before I end, I just want to emphasize key points. First, religious and traditional healers should be seen as complementing public health interventions. We don't need to see them as competing. But if we see them as partners in development, it enhances whatever we are doing. And traditional healers are trusted voices in their communities. In Focus 1000, we say the message is important, but the messenger is even more important, because when you get these religious leaders and traditional healers who are trusted, when they give their messages, it's more easily accepted. The third point is that, you know, religious and traditional healers are very powerful. They have influence. So we should rather use them as complements, use them as part of the solution, rather than seeing them as part of the problem. At one time when we started the campaign, the Ebola, people were saying, oh, it's the traditional healers and the religious leaders who are fueling the spread of the disease. But when we changed that perception and started working with them, they became very supportive, and they were able to enhance, you know, the campaign and reach further reach. The last point I want to make, though, is that there is need for us to coordinate our messages, so that the religious leaders are not saying something different from what the traditional healers are saying, that we have one message. So we bring them together, we develop the messages, make sure the messages are not contradicting the public health messages, and we work as one. So by so doing, we enhance, you know, ease and avoid, you know, duplication of effort and confusion or conflicting messages. Finally, I thank you very much, and I'll be here, you know, to answer any questions that you may have. Thank you very much. God bless.
Thank you. Thank you so very much. Thank you. We will now be transitioning into our breakout groups. And in the interest of public health, take a break from your eyes on the screen. So look away from the screen. And as you do so, you will find that you are automatically being transported miraculously into a group. And we invite you in that group to engage the three presenters and ask any questions and discussions that you want to have. If you can have one person among you make a note, and then when we return, you may want to put that in the chat or put it forth for us to have a lively discussion after your period of time in the groups. And so we will now be moving, we will be transported into our groups.
Okay, I'm going to do this and it'll take about a minute for you all to get in your groups. And we'll give you about 15 minutes and then you will be automatically brought back. So here we go. Okay,
I
Ida,
fear,
Ezra, and
I fear
Mary,
that I
you
fear
need to,
that Pauline and John did not get the message to come right back.
all right, I'll see if I can retrieve them. I don't know
Yeah.
if I can. Mary, Ida, and Ezra, you should click on join if you want to go to your group. And Zipporah,
Unfortunately, I apologize. This is Ida. I need to leave for another meeting.
Oh, okay.
okay, well, thank you so much for
Thanks for
joining
coming.
us.
Yes, it's disappointing that they conflict. I'll be back the next time.
Excellent,
Okay.
thank you.
Thank you.
Thank you.
Let me look at the groups. Well, there's only 3 people in the group that Pauline is in, so I kind of want to leave her there, I think.
Okay.
John is in a group with Kay and with Sue Pak, so I think I kind of want to leave him there too. We'll just let them go, if that's all right.
Okay.
Those are people who can definitely hold their own.
Okay. Okay.
I want to check on the Facebook page right now. We have been recording fine, I think.
Okay. Are you paused? Did you?
Just so you're aware, our little group right here is live on Facebook. I cannot pause that.
Ah, okay.
So if you want to turn off your screen for the 15 minutes, that's fine.
But are you pausing the recording, or is that?
The recording on Facebook is not paused. The recording on my computer is paused.
Okay.
The backup recording.
Okay.
We will return in 15 minutes. If anyone is watching this recording after the fact, you can simply fast forward. Thank you. Okay, we've got a couple of minutes to go and then I'll start bringing everybody back. Hi, Brenda.
Okay.
Hi, Pamela. How are you?
I'm good. It's nice to have you with us today.
I'm sorry. What did you say?
Oh, said it's nice to have you with us today.
Thank you. Thank you. I'm enjoying it.
All right, so they're going to get the 1-minute warning now.
Okay. Mm-hmm. How many groups did we have?
8.
Okay. Okay.
Dr. Jallo, thank you very much. That was really fascinating.
Thank you so much.
It's
It
such a
was my
great,
pleasure.
great example of collaboration. Really
Mhm.
inspiring.
Mm-hmm.
Thank you.
Yes, indeed. Yes, indeed. And such tremendous impact.
Yeah.
You're going from 6% to 75% in a few years.
Well,
That was just very striking. Very striking.
And
especially
life-saving.
at,
Absolutely.
yeah.
Absolutely. Absolutely.
Okay, folks are going to start coming back now automatically.
Mm-hmm.
Here we are.
It was a little too short.
Sorry about that.
We can imagine. Yes. Yes.
Right, feels
Wonderful. And as we return, feel free to put questions in the chat that emerged. I think that we are also certainly on the Zoom, we are a sufficiently compact group. So if you wish to raise your hand or indicate that you want to say something, that is also possible. So we'll use both the chat and any kind of hand signals, whether they be from the panel at the bottom of your Zoom window, or whether it's simply the old-fashioned raising your hand. We'll try to make sure that we are attentive to everyone. So
I will monitor the chat while Emmanuel
wonderful,
continues to
wonderful.
moderate.
Okay, that should be good.
But we
So
have one question in the chat already.
right. So maybe let's begin with that. The question is, what do you think accounts for the differences in pastoral responses in various places? We mentioned education. Do you think it is simply culture or more? So our presenters, would anyone like to reflect on the differences? Fascinating Kenyan, Sierra Leonean, and US in a sense. So what are some of the reasons that we find these fairly significant differences in responses?
I'm happy to respond, but can I ask Devereux to say a bit more? Pastoral responses in various places to what?
Mm-hmm.
Okay. Our conversation in our group was about, it was so interesting to hear from one speaker that the pastors were very fearful and that sort of thing. And then in the other group, there was this sense of, participating and being very involved.
Mm-hmm.
And we were we were kind of wondering, what do you think accounts for that? Why do you think there's such a difference from place to place? And in the United States, we have pastors who are, claiming that it's a hoax, like COVID is a hoax, and then others who are very helpful in trying to help people to get through. I don't know. It was just a question that came up in our group.
I'll let Pauline and Mohammed speak to whether that kind of diversity is seen in Kenyan and Sierra Leonean context, but I do think it is striking the varied kind of responses and where religion fits in responses to COVID. There's a Facebook group of spiritual and religious leaders and practitioners that has about 7,000 members now, from Christian, Muslim, Jewish, Buddhist, secular humanist pastors and spiritual leaders, convened around responses to COVID in local communities. And that aligns very much with public health. There's a real commitment in that group, and it reflects kind of public health priorities. But you're exactly right, Devereux, in other parts of the United States, and that group's not just the US, it's also global. But in parts of the United States, you have lots of religious leaders who articulate a very different message that's actually in tension with public health. I will say that as someone who sits in a school of public health, we don't always do a very good job as a field of taking our scientific knowledge and communicating it in a way that local communities will find relevant or understandable. At times we kind of speak down to communities, and at times we approach the idea of findings out of public health as science, which is real and true and incontrovertible. And therefore all this other stuff, maybe we have to give lip service to it to be culturally respectful, but we don't actually do a very good job of demonstrating cultural humility and respect out of our own culture, and a kind of culture of a kind of scientific priority. And that's what we in public health need to figure out how to do better, is not to assume that our viewpoints on something like COVID are the truth and everything is else just culture that we've got to work through to get the truth out there. We need to do a better job at showing some humility and the culture that created us as public health practitioners to value the science over and above some other framework that's being employed. And I do think part of that is education.
Yeah, can I just add,
please.
Add to that point, what we found in Sierra Leone is the engagement, engaging the religious leaders, asking them to do the research, for them to go to the Bible and the Quran. And we give them the public health messages and say, you go now and look at the Bible and the Quran and see if there are verses that support these messages. So when they go and identify, generate their own evidence, it becomes even more powerful, and they own it. And they use it now to go and talk to their own people. So the issue, like John is now saying, as outsiders going in and talking down to them, that one is addressed to a large extent, because you are getting them trained as trainers who go now, they know how to talk to their own people. You just allow them now to go and use the same Bible and the Quran. And we found out that they themselves confess that, oh my God, we didn't know that, there was so much evidence in the Bible and the Quran that we can use to support these messages. So I think that is very powerful for us. Thank you.
In our group dream, there's something very important that this young man next to me said. I would like him to say himself.
Yes, thank you so much. One of the challenges that we are facing in response to public health is the fact that I think from the beginning, science has been always presented as an alternative to faith or to religion or to spiritual care. So it's like one is either believing in God or is believing in science, which I think is not supposed to be that way. Science and religion is not the opposite alternatives, but they are complementary. They work together. The God of science is the God of religion. So even when it comes to education, it is, I think, high time that theoretical institutions incorporated science within the curricula of the religion, in that the people are taught to be are trained for ministry. They're also equipped with knowledge in public health, knowledge with epidemiology, so that instead of rather than relying on public health messages that are created by other people, they can also be on board to relevantly come up with the messages and interventions that are interlinking both the science and then also the religion. And with that, I think we shall be responding more relevantly to these public health challenges.
Right, right.
And Rosie
Yeah.
Morton in the chat has actually made a very similar comment. I wonder if Rosie, if you want to say anything more about that from the Western perspective.
Well, really, just I can't thank you enough for organizing today. I think I would actually like to tap into the expertise in this group. I am currently fascinated by, particularly in COVID, how do we move on the debate? I guess I live in a part of the world far too influenced by narrowness of thinking. So people often think science on the one hand, faith in the other, but in real life, those go together. How do we bring that together? So I want to ask that to the group, because I don't have the answers, but the group will.
Yes, thank you so much for that. And there's a question here that I think is very close to that from Estrella, and it's the question about how do you manage fake news and misinformation, and this in the public sphere, so how can we bring the religious discourse where there is fake news within the religious discourse, and then the public discourse, which is a mixture of science and public. Sometimes it's a mixture of popular kind of sentiments. So I think that what we are trying to seek cooperation of can contain both falsehood and reality. And how do we manage that?
I don't know. I can start. Our experience is that that's exactly what we are saying. If you have the public health practitioners going out and giving their own messages, then you just leave the religious leaders and the traditional leaders doing their own thing. Remember, they are very powerful. They have a lot of influence there in the communities. Then they would be able to give any and every message, which may or may not contradict what we are saying. But what we have done is to bring those powerful religious leaders, not as individuals, in fact, heads of churches, heads of mosques, and heads of organizations, give them the public health message, and I'll say, look, challenge them. You go into the Bible, go into the Quran, get your verses, support these messages, and you are out there now giving the messages. You are on radio, you are on television, giving the messages. So when your congregation listens to you, instead of now getting the fake messages from the religious leaders and the traditional healers, they are the same ones who are giving the scientific message, and backing it up with the religious messages. I think that is one way to do it, and it becomes very, very powerful. Thank you.
Okay.
I can also say something.
Please do.
In my research, I found that the grandmothers challenged the false information from the pastors. For example, when the pastors refused to offer them pastoral care, and they say that the children who are dying of AIDS were rightly doing so because they were being judged by God for sexual immorality, then the grandmothers challenged that by saying they did not believe that God would condemn people to such suffering. So they were eager to find out what was the cause of suffering, what was the nature of suffering that their children were suffering. And that's how they educated themselves. So they entered into spaces where they got trained on HIV. and they understood the disease. And therefore they said, we now understand this disease, but our pastors still do not understand this disease. So we would like to bring them on board. And somehow theology emancipated or began to move from the grandmothers to the pastors instead of the other way around. And in the World Council of Churches also, how we try to combat the fake messages is by checking it alongside our checkpoint is this theology or is this message life affirming? Deriving from Jesus, John 10:10, I came that they may have life and have it in abundance. So if it is a cultural norm, is it life affirming or life demeaning or life threatening? If it's a theology that says we can all take communion from one cup, for example, or one spoon, or that says we can all go to church and dance without our masks on, COVID will not come to church. Is that theology life affirming or life threatening? So our checkpoint therefore begins by eliminating that which is not life affirming and it's life threatening, then we take it as fake. And we counter it with scripture, where then scripture helps us to dig out and find life affirming norms, life affirming language, life affirming messages.
Before we begin to close, I would like to try to get Sue Pack's group in. You've got a couple of very interesting questions that you've put in the chat.
I'll just speak very briefly. We had a really wonderful conversation around the kind of the dynamics of the individual and the communal nature of that John had talked about, of spirituality and public health, when actually it doesn't have to be that with a paradigm. It's spiritual, it doesn't have to be individual, and we're looking at other models of spirituality that is public. But in that conversation, we talked about what is public and how the public health programs may be conceived, designed, and implemented may have in its algorithm something that further marginalizes the already marginalized groups. So the question we wrestled with is, who is the public, and for whom, and who benefits from the public health programs? And is there any, should be surprised that some communities are very suspicious and resistant to going along with public health programs as they're rolled out, if been consistently marginalized, and health inequities and life inequities and all the isms that play a role. So that was that we really kind of wrestled with that. And the other question that I put in the chat is how little, I don't know, I'm looking from our seminary, I'm looking at my dean here, Pam Cooper White, and we don't actually talk or teach about public health in any meaningful way. And maybe that's something we need to really consider. Even in the midst of the pandemic, we talk about inequities around it, but we actually don't know how to even talk about it from a public health perspective. So anyway, those are the conversations we had.
If anything, this webinar has proven the importance of that conversation within theological education and within spiritual care profession, because you can't really accomplish the one without the other. And it's not only true in non-Western contexts, but certainly in the United States, where Black and brown people have been disproportionately hit by COVID, and quite rightly are suspicious of vaccines and trials after some of the atrocities that have been committed in those communities in the past. And so this is something that affects really all societies across the world in different ways. Wherever there is racism, there is going to be a need for that conversation.
Let me just say that in relation to, but quickly in relation to both of those topics, I do think that there are practices in public health that can give us some insights into the critical question Sue named and that we discussed in our group about this question of social systems and social structures, and not only engaging those in the mainstream, those with the most social capital, because that's what public health might want to do, but to recognize that those systems those social systems and structures also marginalize some groups and some communities. And it's really essential for public health that thinking about addressing social structure or environmental factors, that we engage the margins and not just the center. And HIV taught us that. A lot of Pauline's work, what Pauline was speaking to, and what she and I think Niambura, her colleague working in Ihaya, have done through the World Council of Churches, of listening to the religious and spiritual lives, not just of pastors, priests, bishops, imams, but of grandmothers who speak back to those pastors and priests to testify to the Spirit at work outside of sources of authority. And I think it's really important that we just not recount that anecdotally, but we name it structurally. And then,
and John, I just want to throw out the word gender. That this is a very gendered issue.
Absolutely.
In relation to the power of women to say revelatory responses around that kind of
yes, I mean, especially when you think about intersectionality, that there's a double whammy often between issues of gender, issues of race, issues of traditional religion versus hegemonic religion. And women, when they band together, like the circle of theologians in Africa, often can say things to the church that the hierarchies have never considered.
Yeah, absolutely. And it's important for us in public health to not only partner with councils of bishops, but also with the circles of African concerned women theologians. It has to be both and not either or. And we overlook those networks and how functional they are and how prophetic they are a lot of times. I'll also, and Emmanuel, I'm going to include you in this. You can weigh in whether you want to or not, but we at Emory do a lot of work in the intersection of religion and public health. We have a collaborative across 7 of our academic units. We have the Interfaith Health Program. We have a certificate program in religion and public health. We have a dual degree program with a Master of Divinity or Master of Theological Studies and a Master of Public Health degree. That's not to say you need to come to Emory and look at it and not to Union. That's to say if colleagues at Union or at other seminaries would like to talk with what we're doing at Emory, we'd be happy to do that in another time.
I think at the end,
I think the certificate in religion and public health requires that theology students take public health courses in the School of Public Health. So that's just to underscore what John was saying. But certainly a thing that is coming out of our conversations today is the great need for theological students to actually be seriously exposed to public health discourse and practice. I think Kay had a thing. Would you? I think this will probably have to be the last, given our time.
Yeah. So in the
so
same,
just a few words, Kay.
So in our conversation, just I want to conclude with this word. I think the critical question here is what kind of spirituality for individuals and the communities are informing their sense of responsibility. So individuals as socially responsible beings, and because each person has different range of responsibilities. So the simple question is, whom do you think you are responsible for? I think that really clarifies the shape and the boundary of each communities. And then public health question is, how can we make the community more broader, like to include everybody, I think. And what kind of spirituality is informing that is really a task for faith leaders also.
Yeah, thank you so much. And there's so much. We do want to say that we are actively pursuing publication for all of these webinars that we're having, and we do encourage our participants, our panelists, also to share what they're writing and what they are publishing. For the wider consumption of us all. But I want to thank our panelists sincerely. Thank you so much from Sierra Leone, Mohamed Jallo. Thank you so much, Reverend Pauline Injiru from Nairobi, Kenya. Thank you for being a part of this lively and very, very significant and important conversation. Thank you, John, for participation. And thank you, one and all. We look forward to next week when the panelists will be from the discipline of psychology. Thank you. Thank you so much. Thank you.
Thank you
Thank you.
for moderating. And in response to Patricia, if anyone does have another article that you'd like to put in the chat right now, I will leave the meeting open just for a few minutes so that those of you who want to share resources can do so in the chat. Thank you all.
Thank you.
And we hope to see you next week for our next presentation.
Okay.
I believe it's on the topic
Bye-bye.
of psychology, is that right? Yes.
Good. Bye-bye. Thank you.
Thank you. Goodbye.